In between seeing patients in the ED, you get a notification on your phone that your salary just dropped into your bank account, and you wonder, what am I supposed to do with this money? Am I supposed to save it or invest it or what?
The next patient that was brought for your evaluation is a child who had a recent sore throat coming in with fatigue, shortness of breath, and intermittent chest pain. And you wonder, is this another viral syndrome or is this something more serious, such as a cardiac complication from a recent infection?
In this episode of Critical Decisions in Emergency Medicine, we will talk about savings and investment strategies for physicians.
We will also talk about pediatric acquired heart defects, including their diagnoses and management.
With you is Dr. Danya Khoujah. I'm an emergency physician that practices all over the world.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the December 2025 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss two lessons that are bread and butter emergency medicine or things that are cutting edge.
There's more than just the two lessons. There's also other features such as the critical image, clinical pediatrics, as well as our mini pearls from the drug and tox boxes.
And for our first lesson of this issue, we have Sacred Heart, Pediatric Acquired Heart Defects. Thank you to Doctors Matthew Carvey, Joelle Brown, and Jonathan Glauser for writing this article. So pediatric acquired heart defects can be quite challenging to diagnose. What may begin as a seemingly innocuous infection can result in these cardiac complications and potentially devastating long-term consequences.
Indeed, it can be quite scary. And so when we think about acquired heart defects in the pediatric population, generally we're talking about rheumatic heart disease, sequelae of Kawasaki disease, hypertrophic cardiomyopathy, as well as Lyme carditis.
So let's start with rheumatic heart disease. What is it and how do we diagnose it?
Well, rheumatic heart disease really starts with initially an untreated group A strep infection, so generally a pharyngitis presentation. And about 2 to 4 weeks after this untreated infection, patients can have an autoimmune response that develops that can affect many organs, whether it's the heart, the joints, the nervous system, or the skin. In this case, we're of course focusing on the heart condition, which is rheumatic heart disease. So when we talk about rheumatic heart disease, the most common presentations and symptoms affect the mitral and aortic valves. And if these are still left untreated, you can have progressive stenosis or regurgitation of these valves, also leading to atrial fibrillation, endocarditis, and pulmonary hypertension. If we recall, acute rheumatic fever, which is when you're dealing with the overall autoimmune response from this initially untreated group A strep infection, we make the diagnosis using that Jones criteria. And in 2015, there were some modifications to the Jones criteria that's shared in Table 1 of the article. As a refresher, there are major criteria and minor criteria to the Jones criteria for making this diagnosis. And the particular updates and modifications are that when we're looking for cardiac signs and symptoms of these complications, carditis, it can be clinical, such as finding of a murmur on clinical exam, or now you can substitute it with echo or Doppler findings. And in patients who are moderate or high risk for acute rheumatic fever, now both monoarthritis and polyarthritis are accepted as a major criteria for the diagnosis. So definitely take a look at the table to refresh our memories of all the components of this.
So how do we treat acute rheumatic fever and rheumatic heart disease?
Since this began with an untreated group A strep infection, there's definitely the antibiotic therapy that we want to eradicate the infection. So classically, we use a penicillin derivative, which most commonly benzathine pen-G intramuscular injections. For patients who are allergic, you can use oral erythromycin. And then the sequelae, which is an immune response, we usually utilize anti-inflammatory therapies. In this case, high-dose aspirin in the acute phase, sometimes even corticosteroids, especially in cases with cardiac presentations of carditis. We also provide symptomatic treatment with NSAIDs if patients have any arthritis related pain. And then, in terms of secondary complications of the rheumatic heart disease, you may actually have to provide goal directed medical therapy for heart failure, such as using diuretics, ACE inhibitors, or even beta blockers for patients presenting with AFib.
All right, let's move on to Kawasaki disease. How do we make this very difficult diagnosis?
If we recall, Kawasaki disease really affects, again, also multiple organ systems, and it's really characterized by a overwhelming inflammatory response as well. And it's actually the most common cause of pediatric acquired heart disease in the US. And while we don't know the exact cause, this exaggerated immune response is often seen after a viral or environmental trigger, and it can present with, again, organ injury, acute vasculitis. In this case, and particularly concern would be involvement of our coronary arteries. If left untreated, 25% of these patients can develop coronary artery aneurysms, which of course is very scary, and have other complications like thromboses, MI, as well as sudden death. And this is most commonly seen in children younger than 5 years, but it can affect children of all ages. In terms of the diagnosis, there are also thankfully some criteria that's established by the American Heart Association. And so for the complete Kawasaki disease diagnosis, we're talking about a fever for at least 4 days and at least four of the five major clinical findings, which involves polymorphous rash, conjunctivitis without exudate, mucosal changes, extremity changes like edema of the hands and feet, and then cervical lymphadenopathy. Of course, not every patient will present with all of these symptoms, and so patients can have atypical Kawasaki disease, which we generally make the diagnosis with fever again, of course, and then two or more of those clinical findings that we just described, as well as using some laboratory findings that is suggestive of inflammation, such as elevated CRP and ESR, or maybe things like thrombocytosis, low albumin, leukocytosis, etc. Now, in terms of in the ED, the most important thing is if you're concerned about this, of course, you're going to send some of these workup to help you hopefully make the diagnosis, but you should definitely get an ECG and an echo to, of course, evaluate the coronary arteries.
Got it. So, how should we treat Kawasaki disease?
To treat this overwhelming immune response, we're going to actually give IVIG, immune globulins. And in this case, it would be 2 grams per kilo, administered over 8 to 12 hours. The key, though, is if you're suspicious and concerned, you should not wait for some of these diagnostic tests, such as your echo. You should just initiate treatment because we want to initiate treatment as early as possible to, of course, reduce the complications like coronary artery aneurysms. You also want to give aspirin, moderate or high dose, until they're afebrile for at least 48 to 72 hours, then transition to a low dose aspirin for 6 to 8 weeks. In patients who are resistant to some of these initial treatments, they may even need corticosteroids or immunomodulators. Of course, talk with your pediatric cardiologist because they can help you out with this particular evaluation and management as well.
Well, Wendy, you keep talking about this overwhelming immune response, and it just making me think of the multi-system inflammatory syndrome in children that we saw with COVID-19. How is Kawasaki different from that?
Absolutely. There's a lot of clinical overlap as we think about these conditions. So, this MISC that we saw in COVID also presented with fever and these inflammatory markers that are elevated in two or more organ system involvement. Some differences are that patients with MISC, their cardiac involvement generally present as myocarditis or ventricular dysfunction rather than this vasculitis, coronary artery process that we just talked about in Kawasaki disease. And because it is more of a myocarditis and ventricular dysfunction pictures, oftentimes these patients will present hemodynamically unstable or even in cardiogenic shock. Treatment is the same though, in terms of IVIG with or without corticosteroids, along with aspirin or even antiplatelet therapies.
Got it. So let's talk a little bit about hypertrophic cardiomyopathy. What should we know about it in the ED?
We definitely are familiar with hypertrophic cardiomyopathy in adults. And so in the pediatric population, oftentimes we think about similar causes like genetic or even other conditions like malformation syndrome, neuromuscular disease, etc. I think the key in the ED, though, is having a high index of suspicion for a clinical presentation, such as chest pain, shortness of breath, and syncope with exertion, especially if there is also associated family history of sudden cardiac arrest or arrhythmias in childhood. If you're at all suspicious, an EKG should be obtained, but likely you've already obtained it just based on their clinical symptoms that they're presenting with. But you can actually make the diagnosis on ECG. Common findings would be LVH, biventricular hypertrophy, and isolated pathologic Q waves. If the ECG does suggest diagnosis, then of course you want to get an echo to really make this confirmation. And if patients are symptomatic, then maybe they need to be treated with beta blockers or occasionally calcium channel blockers to reduce that gradient across the left ventricular outflow tract to improve their cardiac output. For patients who do not respond to medical therapy, they may even need a septal myectomy done by pediatric cardiothoracic surgery.
Got it. All right. So, how about Lyme carditis?
Yeah, we certainly talk about Lyme carditis as a possible complication. And so, as a refresher, as we all remember, Lyme disease can present with three stages: early localized, early disseminated, and late disease. And when we talk about cardiac complications, we're really talking about that middle stage, early disseminated disease that typically occurs 4 to 6 weeks after the initial tick bite. When you are suspicious for it in the ED, we want to start with the ELISA as a screening test. And if that is positive or equivocal, follow up with the Western blot. This is usually done already by your lab. And so hopefully that particular process is in place. Sometimes the question comes up on whether or not we need to get Lyme antibodies. That's generally not as helpful for us in ED since we don't get those results back. And so we're really talking about initiating treatment in the ED largely based on our clinical suspicion. And so patients who are presenting with Lyme carditis, where there's inflammation in other cardiac tissue, we're really talking about AV blocks that can range from a mild first degree or even a severe third degree block. They can also have myocarditis and pericarditis presentations. And so potentially these patients may need pacing to stabilize them, but most importantly, they need antibiotics for a total of 14 to 21 days. In the case, again, of Lyme carditis, we want to provide IV ceftriaxone.
Got it. Well, thank you, Wendy, for taking the time to review these very scary diseases, but important to know in our pediatric population. We talked about rheumatic heart disease. It was news to me that they updated the Jones criteria. So the revised Jones criteria are mentioned in the article to diagnose initial as well as recurrent acute rheumatic fever. And the treatment for that is antibiotic therapy as well as anti inflammatory therapy, which is high dose aspirin and steroids as needed, as well as symptomatic treatment with NSAIDs. And if rheumatic heart disease were to develop, then at that point it would be diuretics, ACE inhibitors, and beta blockers. With Kawasaki disease, you mentioned the 2017 criteria, which is a fever for a minimum of 4 days, plus 4 of 5 major clinical findings: the rash, conjunctivitis without exudate, mucosal changes, extremity changes, and cervical lymphadenopathy. And then, of course, patients may present atypically with only 2 of these findings, but in that case, they would have an elevated CRP or ESR as well. And those patients need to be treated with IVIG as well as aspirin. An important differentiating element from the MISC, the multi-system inflammatory syndrome that we saw with COVID, is that with Kawasaki, they are a lot less likely to present with hemodynamic instability and cardiogenic shock as they would with MISC. And they are more likely with Kawasaki to have coronary artery dilation. We also talked about hypertrophic cardiomyopathy, which is overwhelmingly genetic in nature, and therefore a good family history is helpful here. An ECG is an important part of the diagnostic workup. with evidence of left ventricular hypertrophy or biventricular hypertrophy, as well as pathologic Q waves. These patients need an echo to confirm the diagnosis, and then will need to be treated with beta blockers or occasionally calcium channel blockers, as well as consideration of surgery if needed. Last but not least, depending especially on where you live, Lyme carditis is a question that comes up more often than it should. Lyme disease can be early localized, early disseminated, and late disease. Lyme carditis can be part of the early disseminated disease and may present with or without a rash. So for an endemic area, that's something you definitely need to think about. The lab diagnosis is a two-tiered process. First, you do your ELISA, which is sensitive but not specific. If it is positive, then you order the specific Western immunoblot test. These patients would also get an ECG that may show AV block. Anybody with a PR greater than 300 milliseconds on their ECG or any signs of myopericarditis should be hospitalized, and treatment is with IV ceftriaxone for these cases. So moving on to our critical ECG this month, this is a very scary ECG of a 72-year-old woman who presents with palpitations and recurrent syncope. On the monitor, she has a rapid, regular, wide QRS complex tachycardia with a rate of approximately 195 beats per minute. Looking at this ECG gives me tachycardia, as it's very scary looking. Of course, as soon as we see regular wide complex tachycardia, we all think of VTach, which is exactly what this patient had. The most common causes are structural heart disease, such as a prior MI or chronic ischemic heart disease or non-ischemic cardiomyopathy, as well as things like electrolyte disturbance, drugs, and congenital heart problems. Some hints that it's a monomorphic ventricular tachycardia is the rapid rate of 180 to 200 beats per minute, regular rhythm, and a wide QRS complex from 0.12 to 0.15 seconds. Another hint that it is likely to be monomorphic VTach is that there's AV dissociation. So the P waves are not really in any connection with the QRSs. However, this is not necessary for the diagnosis, as it only occurs in 50% of the cases of VTach. In this particular case, the patient did well after amiodarone, which caused her to be hypotensive, and then she got cardioverted, but then she did well without recurrence of her symptoms.
Scary indeed, but glad she did well. For our clinical pediatrics this month, we have a 17-year-old boy presenting with a rash. It began on the forehead and has been rapidly spreading. Initially seen at an urgent care and diagnosed with impetigo, it was prescribed mupirocin, cephalexin, prednisone, and cetirizine, but did not get any better, so came to see you. The rash is both painful and pruritic. You'll take a look at it. There is a vesicular and punched out appearance to it. The forehead rash has a crust over it, but you do see extension of the rash down the neck, down to the upper extremities. And so you're highly suspicious for HSV infection, and so you started the patient on IV acyclovir and oral clindamycin and admitted them for suspected eczema herpeticum with a superimposed bacterial infection.
So eczema herpeticum is a dermatologic emergency that requires immediate initiation of intravenous antiviral therapy. Eczema herpeticum typically presents as disseminated non-group vesicles and pustules on an erythematous base. It's more common in children than adults, and patients with atopic dermatitis are more likely to be at risk for HSV infection. Something to keep in mind as well is that many cases of eczema herpeticum occur in non-white populations. Patients may present with systemic symptoms as well, and there's always a risk of superimposed skin infections such as staph. The differential includes things like impetigo, hand, foot, mouth disease, eczema coxsacum, varicella infection, herpes gladiatorum, and disseminated molluscum contagiosum. So moving on to our LLSA Literature review, our article is by Munshi et al., Non-Invasive Respiratory Support for Adults with Acute Respiratory Failure, that was published in the New England Journal in 2022.
I think as ED physicians, we're all quite familiar with these various modes of non-invasive respiratory support, whether high-flow nasal cannula, CPAP, or non-invasive positive pressure ventilation, classically provided as BiPAP. But this is a great refresher on some of their differences and particular considerations. And so oftentimes patients are presenting with undifferentiated respiratory insufficiency and respiratory distress, and we may reach for one of these tools. With high flow nasal cannula, we're talking about a specially designed nasal cannula that can provide, of course, high flow rates of oxygen, and that allows you to titrate the FiO2 up to 100%. With this high flow rate, there is a small amount of PEEP that can be provided, but you can't titrate it like the other modalities that we'll talk about. And so classically, we think about high flow nasal cannula as a good tool to improve oxygenation. But the article does highlight that there should be particular caution and careful monitoring of these patients because of the risk of prolonged increased work of breathing with decompensation if the patient is not provided with adequate ventilatory support. Now, in terms of CPAP, we know that this is a continuous, consistent amount of positive airway pressure during both inhalation and exhalation, and that can often ease the patient's work of breathing, keep the airways open, and help recruit poorly aerated alveoli. And classically, we use this in decompensated heart failure because this can help decrease both preload and afterload. Now, while CPAP does not specifically and directly improve ventilatory support through all these other indirect mechanisms, it does tend to improve patients' work of breathing. And so it can be, once again, quite effective, not only improving oxygenation as well as some of the patient's work of breathing over a range of pathologies. And finally, with non-invasive positive pressure ventilation, classically thought of as BiPAP, we're providing, of course, higher airway support for inspiration and a lower during the expiration phase, which is the PEEP. So this differential between the two airway pressures really augments ventilation and decreasing the patient's effort overall in their work of breathing. And this is more beneficial when we're specifically dealing with patients who are presenting with hypercarbic respiratory failure. There's also some utilization of these strategies for helping patients wean from the ventilator. But I think the key takeaway I have from this article is that we should always monitor these patients for potential for decompensation and whether or not they may need invasive ventilatory support. Now, moving on to our critical procedure this month, we're talking about Bartholin cyst drainage.
While Bartholin cyst drainage is definitely painful, it's just like a regular IND. However, a balloon catheter can be placed in the gland, or marsupialization can be performed to help prevent recurrence. It's important to remember that marsupialization is contraindicated if there's overlying cellulitis.
Like you mentioned, the patients are presenting already with lots of pain and possibly a great degree of anxiety, and the procedure itself can cause more of that. So please do provide analgesia, both topically and likely systemically, and any anxiolysis if necessary. And you would set up the procedure, clean and prep the incision site as you normally would for any IND. You do want to make an incision on the mucosal surface rather than the skin surface, large enough to allow for drainage, but small enough to allow for packing or placement of the balloon catheter, depending on what you feel may be indicated. And then also consider whether the patient will need antibiotics and potentially a culture sent from the drainage. One other consideration is that there are some cases of Bartholin cysts that are associated with cancer, especially in women older than 40 years. And so some experts have recommended sending tissue samples to pathology if marsupialization is performed.
Great tips. So, moving on to our critical cases in orthopedics and trauma, we have a case of a 14-year-old boy who's presenting with a knee injury with deformity while playing football.
When he presented, he tells you that he had immediate pain and was not able to ambulate. And you find that he has a very deformed and diffusely swollen knee, but thankfully no open fracture. It is tender to palpation. He has a limited range of motion. So you get some x-rays and you find that there is a displaced distal femur fracture.
Distal femoral physeal fractures represent approximately 1% of all pediatric fractures, but are associated with a disproportionately high risk of growth disturbance. Salter-Harris 2 fractures are the most common subtype. In children with open growth plates, hyperextension trauma tends to injure the distal femoral physis rather than the nearby ligaments. Physeal fractures can be occult on initial imaging and should still be suspected in patients with a joint effusion, inability to ambulate, or a concerning mechanism of injury, even when you cannot see the fracture on initial imaging. As a reminder, with Salter-Harris 2 fractures, the fracture line extends through the physis and exits through the metaphysis, creating the classic Thurston-Holland sign, a small triangular metaphyseal fragment that remains attached to the epiphysis. It may be quite subtle in young children because their growth plates are still radiolucent.
In terms of our management, we want to immobilize the fracture with a long posterior splint or a knee immobilizer. Certainly provide pain control, neurovascular monitoring, and early orthopedic consultation, since many of these often require anatomic reduction and fixation to prevent these potential growth disturbances. The major complication, as we mentioned, is the risk of premature growth with plate closure, angular deformity, and limb length discrepancy. And the most serious complication in terms of physeal growth arrest can occur in more than half of the cases. So definitely have a high index of suspicion for these potential injuries.
And moving on to our critical image this month, this is a case of a 53-year-old woman with concern for a breast mass. She comes in with a lump that she noticed in her right breast around 2 months earlier. It has increased in size, her nipple has become retracted, and blood has come out of it intermittently. She also noticed some shortness of breath, numbness and weakness of her right leg, and no back pain. On examination, you note an abnormal gait with weakness of her right hip flexion. So the emergency physician obtains a CT of her head, chest, abdomen, and pelvis.
In terms of patients presenting to the ED with breast masses, certainly we have a differential diagnosis that not only includes malignancy, but also benign fibers or cystic breast tissue, abscess, or even in some cases, vascular malformations. And the workup that's recommended by the American College of Radiology includes a range of imaging from digital breast tomosynthesis, mammography, or ultrasound. If on clinical exam you're finding, like in this case, skin dimpling, nipple retraction, that you're suspicious for malignancy, then our focus often in the ED is not just only on the breast mass itself, but also the potential complications of suspected cancer and metastatic disease. CT is not included as a diagnostic test by the ACR criteria for palpable breast mass evaluation, but certainly in its use in evaluation of other conditions, that has been extrapolated and provides some data on its sensitivity and specificity for making a diagnosis of breast cancer. One particular take-home point is that while malignant masses may commonly enhance with IV contrast, and benign breast masses may have smooth borders, over about a third of malignant masses also can have smooth borders, so definitely don't just hinge on what the likely etiology of the mass is based on appearance on CT.
Definitely a scary case. Moving on to our second lesson of this issue, we have Save the Day, Savings 101 for Physicians. Thank you to Dr. Laurel Barr for writing this article.
Danya, I didn't think of it this way before, but financial decisions are the critical decisions we make in our lives.
Exactly. And we often don't think of it, but these important decisions have very conflicting advice when we try to listen to quote unquote experts. And this article sheds some light on savings and investment basics that would allow us to address this part of our professional lives with clarity and confidence to allow us to focus on other things as well.
That makes a lot of sense. So let's start with some definitions and clarifications about some terms we may have heard before.
So there's a lot of terms that are mentioned in this article, and I think that this is one of the many, many reasons actually I really like this article, is that it simplifies concepts and words that you're going to hear in other resources so that you're able to actually digest the terminology with ease. So one concept is net worth, which is a measure of a person's wealth and financial health, and it's calculated by subtracting the person's liabilities from their assets. Assets are things that a person owns that have monetary value. Things like savings, investment account, home equity, ownership, intellectual property, and so on. Liabilities are your financial obligations to others, such as debt, mortgage, and so on. Now, expected net worth is a calculation to figure out how much money you will have in the future. And your expected net worth would be the age times the taxable income divided by 10. Although this is definitely a very variable calculation depending on spending habits, savings, and things like that.
That makes sense. So, we also often hear about these rules. What is the 4% rule and the rule of 72?
So, the 4% rule can help investors decide how much money they need to save to have enough income in retirement. So, in order for you to know how much money you need in your portfolio, you need to figure out how much money you want to withdraw each year. And then the calculation would be safe withdrawal equals portfolio value times 4%. So, a 2.5 million portfolio must be saved for $100,000 to be withdrawn annually. The rule of 72 is an estimate of how many years it will take for an asset to double in value. And the way you do that is you divide 72 by the interest rate on the investment and you figure out that time. It's important to remember that compound interest allows assets to accumulate exponentially as long as they are invested. And that is an important concept of why we need to invest early and invest often.
Absolutely.
The article has a ton of great examples that actually clarify all these terms and rules that I just talked about because numbers make sense, at least for me, when I look at them. So definitely check the article out.
Now, are there any general frameworks or steps that we should think about in building wealth?
So the article does mention a 7-step approach to accumulating wealth as a physician. 1, find a preferred specialty and find a preferred job. 3, save 20% of your pre tax income after training. 4, pay off your student loan debt within 5 years. 5, invest broadly, and we'll talk a lot about that later in this article. 6, work for 25 to 30 years. 7, enjoy life because now you know you have a plan. And 8, do not get divorced.
That's very true. There are a lot of parts to this, though. So, how do we create a financial plan?
Well, just like any plan, a good financial plan should be specific enough to guide the investor's choices, yet flexible enough to respond to life events and uncertainty. Basically, the plan would have not just the amount of money that you need to save, but also the length of time for accumulation and the goals for your savings. So, are you saving for retirement, for a wedding, for tuition, for a home? What's a target date on those things? And that way, you can have these goals that you can track for progress and then adjust your plans accordingly. By using that 4% rule we talked about, you can figure out how much money you need in retirement. And by understanding the rule of 72, or there's something called a future value calculator that you can find online, you can determine if what you're doing right now to your savings will add up to your goal of your overall savings.
Makes sense. So, where should we invest or keep our money?
So you can keep your money in a savings account, like a short term savings. And those are conservatively managed taxable accounts, like a high yield savings account, a money market account, or certificate of deposit, CD. It is a complete waste of money to keep your money in regular checking or savings accounts because they do not keep up with inflation. With high yield savings account and money market accounts, they're immediately accessible, but funds in your CDs are going to be held for an agreed upon time. So it can be anywhere from 18 months, 24 months, and so on.
What about investments? Let's talk more about that.
So, in order for us to understand our options for investments, we need to understand the tax system, as this will influence what type of accounts we want to invest our money in. The article does a really good explanation for the concept of how taxes are taken out of our income, which interestingly, not a lot of people understand. So there are taxed accounts and tax advantaged accounts. Typical brokerage accounts, your money is taxed 3 times. You pay income taxes, you are taxed on dividends, and then when you withdraw money from the account, you are taxed again. And then on top of that, you may also have an investment fee. With tax advantaged accounts, you have either a tax deferred or a tax-free product. What this means is that you pay less taxes than you would on just a regular brokerage account. With retirement accounts, there's multiple types. You have your traditional versus Roth. With traditional accounts, those are the ones that are called tax-deferred accounts. They're only taxed once at withdrawal. With Roth accounts, they are called tax-free accounts, and they're taxed only once when you pay your income taxes before contributing to that. You do have employer-sponsored plans like 401ks, 403bs, 457bs, and so on, and those really depend on what type of employer you have. Keep in mind that for 401k plans, contributions can be made by both the employee and the employer, which basically means that your employer is just giving you a bunch of money to put in your tax-deferred account. All of these accounts have maximum contributions and a lot of rules related to when and how you can take the money out. So it's important to understand that. Now, if you don't have an employer and you are self-employed, then there are multiple options. There's like a solo 401k, a SEP or a simplified employee pension plan, a traditional IRA, a Roth IRA. And then on top of all of those, you actually have education and healthcare plans that you can invest your money in. For education plans, you have your 529 account to fund qualified educational expenses, and those are triple tax free. So you don't pay taxes on your income or when they grow or when you withdraw, as long as you use it in the correct way within the limits. For your healthcare plans, your health savings account, you have a flexible spending account, and those are 2 different ones that have different rules when it comes to rollover, taxing, and usage. And then childcare plan as well regarding childcare expenses. Finally, you have municipal bonds, which the simplest way to think about it is a loan made to the local government for a specific purpose. And the return on investment is not subject to federal, state, local, or basically any income tax. The article has a ton of high yield information regarding this. It's a lot of stuff, so definitely take a look.
You mentioned Roth accounts. Are these beneficial to emergency physicians?
So if you are able to invest in a Roth account, then definitely go ahead and do so. Obviously, the disclaimer, we're not giving financial advice to anybody, but looking at the numbers, that sounds like a smart idea. Any emergency physician who can contribute to these accounts should do so because they have a lot of advantages, especially if you don't plan on withdrawing any money within the first 5 years of opening it.
Now, what about the classic investments we think about, stocks and bonds and mutual funds?
So when you're looking at what the things are that you can invest in, you have stocks, which are basically purchasing a portion of ownership in a company, bonds, where you're basically lending money to the company or to the government, and commodities, which is an economic good such as a product of agriculture or mass-produced item like grains, gold, beef, oil, gas, crypto. Those are all commodities. Diversification is the concept of investing into different types of things and with different companies. And that way you maximize your return while minimizing your risk. Now, there are ways to diversify without actually doing a lot of the work yourself. That's mutual funds. Basically, they're collections of stocks, bonds, commodities that are pooled into a single fund. And one type, for example, is the index fund, where it follows a specific market index, such as the S&P 500. So it just makes a selection depending on what the market is doing, and then you just invest in that. So it takes a lot less individual work to figure out where to invest your money. ETFs are quite similar to mutual funds, with some differences about the fact that you can buy them at different times throughout the day, and they might be more tax efficient than mutual funds. Another way to diversify your investment is to invest in an REIT, which is a real estate investment trust. These are companies that invest in real estate, and the income for those has very little correlation to the other aspects of the stock market. So that way, even if the rest of your investments are not doing well, this would not be directly affected by that.
Wow, that's certainly a lot of options. So, how can we decide where to start?
So to figure out what type of investment to put your money in, that's called asset allocation. And it's often expressed as a percentage of the total investment. Most conversations are about stocks versus bonds. And the thought is that the younger and more aggressive you are, the higher percentage of stocks that you can have because they're higher risk in the short term. One rule is 100 minus your age to figure out the ideal percentage to hold in stocks. So the younger you are, the higher that percentage would be for you. Also, if you don't really know where to start, you can just invest in a passively managed total market index fund or a target date fund. Basically, you say, hey, well, you know what? I want to retire in 2045. So then that target date fund automatically over time slowly decreases the amount of stocks and increases the amount of bonds as you get closer to 2045.
Got it. Now, what about investment fees?
So you need to know what you're paying for. So are you paying a fee for service? Are you paying a percentage of your investment? Are you paying for investment transactions? So just understand what you're paying for and know if it's worth it. Also keep in mind that a lot of these fees are not transparently disclosed. One more thing to remember, which is really important, that not all financial advisors are created equally. Financial advisors should be fiduciaries, which means that they should be ethically bound to act in the client's best interest instead of their own interest. At the end of the day, know what you're paying for because that over time can really take a cut into how much money you're making out of your investments.
Good advice. Let's put all of this information together and make a realistic plan for our young emergency physicians.
So I think the biggest question here is figuring out what to do with your debt, your savings, your investment. What goes first? What do you do first? So you can choose to pay off your smallest debt completely first while you're making minimum payments on all the other debts, or instead you focus on the one with the highest interest rate first, while of course making minimum payments on all the other ones. And people have different names for them: snowball method, avalanche method, and so on. And there's a lot of online calculators that can help you with that. Different financial advisors and experts have different opinions on how to do this. One interesting way as well is what the white coat investor talks about, where you can kind of do a little bit of both, like the paying off the debt and investing at the same time, where he advises that you alternate between paying off the highest interest debt, invest a little bit into certain accounts, and then the lower interest debts and so on. And the details are in the article as well as his blog.
Well, thank you, Danya, for taking us through this very important lesson, and thanks to the authors for writing it. There's a lot of very valuable information in it, so please do check it out. Like you said, this is one of the most important decisions we make in our lives so that we can have a successful career and life after our career. A few particular tips and tools that the article shares are considering how much money we need to save to have enough income in retirement. And you can utilize the 4% rule to help you calculate that, as well as considering how long it'll take for our assets and investments to reach the target amount by the rule of 72. But the key is to invest early and often, as well as to diversify our investments to minimize risk. Certainly, there are a lot of ways to invest that we went through in terms of the different types of accounts, whether it is tax deferred versus tax free. And so you do want to consider how both play into your overall financial plan, as well as specific retirement plans that many of us have access to through our employers or even as self employed practitioners. Learning about those differences and especially what is the maximum contribution that can be made so that once again we can diversify each of these potential streams to make a balanced plan. By investing early, you're really taking advantage of that compounded interest, and it allows you to utilize potentially investments that are higher rates of return, though potentially higher risk, like stocks, as compared to bonds. And that particular strategy, in terms of how to balance your asset allocations, should change over our lifetime because, of course, most people's portfolios will become more conservative and less risky as we get closer to retirement age. If you do utilize an financial advisor or company, just be cognizant of what exactly you're paying for and whether or not they are acting in your best interest. There are also a lot of other resources that are shared by the lesson in terms of reading materials and general approaches to things. So definitely take a look because there's a lot of information that is enough for more than just a single lesson.
Definitely a high-yield article. So now for our drug box this month, we have high-potency tetrahydrocannabinol, or THC.
We certainly encounter patients who use THC, and this particular product, the high concentration THC, are often used by patients for anxiety or depression, despite mixed or low quality evidence. There was a systematic review that looked at exposure to these high potency THC that found worse outcomes, including development of cannabis use disorder, psychosis, and schizophrenia. Hyperemesis syndrome that we sometimes see is also more common with the higher concentrations of THC.
And last but not least, our Tox Box this month is cone snail envenomation. So apparently, cone snails are tiny little venomous snails that can kill you, and they just hide under rocks and in the sand and along the reefs in shallow waters and tropical oceans. And they can actually poke you through your clothes. So that makes me feel very uncomfortable because apparently death secondary to flaccid paralysis with respiratory failure is reported to occur in under an hour. It happens by inhibition of voltage-gated sodium, potassium, and calcium channels and nicotinic acetylcholine receptors leading to paralysis. And this is more likely to occur with larger shell size and stings in pediatric patients. As for the treatment, it's supportive. Possible hot water immersion of like 45 degrees Celsius might help, and there's no anti-venom available.
I quickly Googled what these snails look like.
They look like craggy little snails.
Yeah.
I know. I'm like, do you look so different? Like, how am I supposed to figure out that you are the scary snail and that you are not the snail that I should be using for my face cream? And clearly there is no way for me to figure this out.
Okay, we are not walking on rocks.
Western Indo-Pacific rocks.
There you go.
Well, thank you, Wendy, for taking the time to go through this issue with me. I've learned a lot. Our dear listeners, we hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decision publication and our podcast always informative, often enlightening, and never boring.
Follow us on social media. My handle on Instagram is at Dr. Danya Khoujah.
Mine is at Dr. Wendy Chang.
And until next month.
Bye-bye and Happy New Year.